Good morning. Thank you very much, Dr. Status, for the introduction. I'm very grateful to be here today to talk about some of our research team studies over the recent years. What I'm going to do is a kind of overview on some of our studies using near-infrared spectroscopy to look at bladder function in health and disease. When light transmits to a living tissue, a part of it would be absorbed by the chromophores inside the tissue. A part of it would be reflected, and a part of it would be transmitted through the tissue. There is a logarithmic consistency and dependence between changes in actually tissue specification, tissue variables like tissue mass, tissue structure, biochemical composition, biochemical properties, and chromophore concentration, and coefficients, absorption coefficients, reflection coefficients, and scattering coefficients. And this consistency defines the behavior of living tissue, each tissue, against the light transmission. So when one of these tissue specifications like chromophore concentration changes, by using light we can detect the changes of behavior of the tissue against light transmission, and this is the basis of optical diagnostics. Optical diagnostics actually is a novel branch of clinical diagnosis using light in different models and specifications. There are different methods like Raman spectroscopy, optical coherence tomography, laser speckle imaging, and near-infrared spectroscopy. Just an example, Raman spectroscopy is one of the optical diagnostic methods using light, using frequency, a wide range of signals of light to look at the tissue biochemical composition. And using this method, people can marginalize the cancerous tissue, for example. It's pretty much used in dermatology, and there is a report of Draga using this method mounted in a cystoscope to look at the margin of bladder cancer. Another method is optical coherence tomography. This is pretty much like the ultrasound, but instead of sending sound wave, in this method they actually send and transmit light. And because considering the speed of higher speed of light, comparing the sound and the intensity of photons, it can provide an image in 2D or 3D in a very high resolution, even at each 2 microsection. And as you can see here in this report of Ren et al., you can see the changes in structure. This is the image of actually bladder carcinoma, comparing the pathology. The only optical method that look at changes in physiology and metabolism of tissue in real time is near-infrared spectroscopy. In fact, near-infrared spectroscopy is an optical method using light in near-infrared spectrum between 700 to 1000 nanometer for non-invasive detection of changes in tissue chromophore concentration, mainly in clinic to monitor tissue oxygenation, hemodynamics, metabolism, and function in real time. Each single set of near-infrared spectroscope consists of a laser generator that generates light. The light will be transmitted through the optical fiber to the optode, and through the optode from the surface of tissue, the light would be transmitted into the tissue. Part of light would be absorbed by the chromophore inside the tissue, and it depends on the signal that actually we send to the tissue. There is another receiver optodes that collect the remainder of the light, and a photon counting hardware will compare the emitted and the received light, and based on that, using a kind of mathematical algorithm, it would be translated to a figure, to a chromophore concentration of the chromophore concentration inside the tissue. So it would be visualized like this in real time. The chromophores that we use in clinical studies mostly are oxygenated hemoglobin, deoxygenated hemoglobin as index of tissue oxygenation, total hemoglobin as a kind of index of local hemodynamics and blood flow, cytochrome C index for looking at the cellular function at the mitochondrial level, and water for looking at the tissue hydration. There are some other investigation chromophores like glucose and lactic acid that people are working on that. So in future, to monitor blood level, perhaps we just touch uptode and using near-infrared spectroscopy, it can define the blood glucose level. There are some advanced configuration of NIRS that can provide us some absolute measure of tissue oxygen saturation, an absolute number, which is very practical in medicine. In this configuration, this is one of them, spatially resolved configuration. Instead of just one emitter and one receiver, there are several emitters at a fixed interrupted distance, and using kind of algorithm, this configuration can define oxygen saturation of tissue. NIRS has been used in clinic during the last 10 years, mainly to look at brain oxygenation, monitoring brain oxygenation, monitoring limb hemodynamics, and looking at vitality and viability of graft tissues in plastic surgery especially, and to look at muscle function, and monitor actually muscle function. The main advantages of near-infrared spectroscopy is that it's a totally non-invasive method. It's a real-time monitoring method. It can provide us with some direct information from physiology and metabolism and function of tissue in real time. The validity and reliability of this method has been confirmed in several studies in different disciplines. It's not a complex method. It's very user-friendly. It doesn't need very specific training or education. It can be handheld, very compact, small device, of course portable, and really is not an expensive technology. And there is no interference using near-infrared spectroscopy in clinical setups. The main limitations of this method is that it's based on a complex basic photonics physics, so it needs translates to be translated using softwares. And it just monitor the changes in chromophore concentration. So it doesn't provide the absolute amount of chromophore concentration inside the tissue, except the high-tech, spatially resolved, configured NIRS that can provide us absolute amount of tissue oxygen saturation, still not chromophore concentration. And the depth of penetration of this method is limited to maximum 3 to 4 centimeters from the surface of the skin. So using this method, we can just look at kind of superficial tissues in this depth, up to 3 centimeters effectively, and it's very sensitive to motion. So when we use this method, we have to be able to use some kind of motion removal or artifact removal softwares. Well, reviewing the literature, it's pretty obvious that using near-infrared spectroscopy to look at bladder function has been done mostly at the University of British Columbia by Dr. Linus Snathers and Dr. Andrew McNabb. In fact, these two have been pioneers in this field. I think it's a very interesting story, kind of accidental meeting in 2004 or 5. Dr. Andrew McNabb, who is a pioneer in clinical studies, talked to Dr. Snathers about some odd data getting from abdominal cavity of a pig, and they turned to the fact that perhaps Dr. McNabb receptor was over the bladder. And after that, they started to work together to trying to use near-infrared spectroscopy to look at bladder function. And this is the first human study collecting data from asymptomatic human kind of historic perhaps figure. That was in 2007 that I came on board and joined Dr. Statter's research team, and we started a series of studies, starting with an animal study. The objective was to confirm the consistency and reproducibility of bladder monitoring by NIRS to compare the data coming directly from the surface of exposed bladder in a rabbit model and data coming from the transcutaneous actually part to look at bladder function. We use a 3-channel continuous wave near-infrared spectroscope for that study during filling and emptying, and we showed that the data coming from transcutaneous uptake was pretty similar to the data that we collected directly from the surface of the Detrusor during filling and emptying. Also, we investigated the effect of sequential episodes of respiratory hypoxia on Detrusor oxygenation, and we showed that near-infrared spectroscopy is able to provide us information about bladder oxygenation and hemodynamics. We then moved to the first pilot study to see the feasibility of using bladder NIRS for monitoring bladder Detrusor function during voiding, and this is the first data that we actually captured. We used a 4-channel near-infrared spectroscope, and using a specific networking composition of data, we provided this kind of video to better visualize the bladder wall oxygenation during the voiding. As perhaps you can see here, it shows oxygenation of Detrusor during voiding as voiding starts and continues. As you can see, oxygenated hemoglobin is continuously changing, increasing and then decreasing, while deoxygenated hemoglobin stayed constant. So it showed that during voiding we have an episode of increasing oxygenated hemoglobin followed by decreasing oxygenated hemoglobin inside the Detrusor wall. After that pilot study, we started a clinical trial to establish the normal pattern of voiding using near-infrared spectroscopy. And in different subjects, asymptomatic subjects, we came up with a similar and consistent pattern like this. It's a representative figure of the pattern. And as you can see here, as permission to void actually issued, we see a small rise in oxygenated hemoglobin and total hemoglobin inside the Detrusor, followed by a large and gradual increase in oxygenated and total hemoglobin, showing that during the voiding perhaps there is a inflow of blood inside the Detrusor coming from oxygenated part and deoxygenated hemoglobin actually didn't change. In the next trial, we tried to establish the normal pattern of Detrusor filling, bladder filling during actually natural filling. In that study, we used a compact wireless device for the first time, and that device transmits 3 wavelengths. It's based on the specially resolved configuration, so we could get tissue saturation index, the absolute amount during the study. The data would be transmitted to the computer in the next room, perhaps, and we could actually monitor data even for 8 hours using this device. And this is the consistent pattern that we observed in normal individuals during natural filling. As you can see, when the filling starts, there is a gradual increase in total hemoglobin, let's say blood flow and oxygenated hemoglobin inside the Detrusor by the time that the first filling and then urgency appears. And after that, we actually observed a gradual decrease in hemodynamics of Detrusor and the oxygenation of bladder wall. Our observation supported by previous animal reports. In fact, this study was the first study showing this effect in human. The previous studies done by Brading and Anderson in animal models, rabbit models, showed a similar thing. As you can see here, a decrease at the terminal point of bladder filling, and it shows a negative linear relationship between Detrusor pressure and perfusion, especially in the non-compliant cycle of the bladder filling, the last 1/3 part, mostly roughly. And also it confirmed bladder vasodilation as bladder extends during filling. After establishing normal patterns of voiding and filling, we moved to dysfunctional cases, and we started to see what's the difference, what we observed in asymptomatic subjects with symptomatic subjects. So we actually did some study on people with non-neurogenic, in the first place, non-neurogenic bladder dysfunction, using the same spatially resolved configuration by Nears, and this is a representative figure of a dysfunctional voiding. As you can see, in contrary to normal patterns that we actually observed an increase in oxygenated hemoglobin and total hemoglobin, there was a decrease as permission to void and voiding started. There was a gradual decrease in perfusion of bladder and oxygenation of bladder. We can compare it here. This is a normal pattern and this is a dysfunctional pattern. So that was totally different and detectable. We recently actually did a study on 43 adults diagnosed as overactive bladder as a kind of dysfunctional cases. And interestingly, using urodynamics, simultaneous urodynamics and near-infrared spectroscopy, we observed a significant correlation between positive urodynamics data and positive Nears voiding pattern, also positive urodynamics data and positive Nears filling pattern. So it shows that in most of the dysfunctional people affected by OAB, when the urodynamics is not normal, when the urodynamics is obvious, we can see some changes, some abnormal changes in both voiding and filling phases collected with non-invasive near-infrared spectroscopy. We are still working on that, but our observation was confirmed by studies of Shadgan with his colleagues, and our observation also support previous reports using Doppler ultrasound studies to show a variation of oxygen supply and consumption of the bladder wall during involuntary muscle contraction. To better integrate the bladder wall, especially in obese female, we invented a kind of intravaginal probe. We used this intravaginal probe and connected to a conventional near-infrared spectroscopy. The objective was to look at bladder wall, but at the same time we could get some data from the pelvic floor muscles. So mainly using this device we could monitor pelvic floor muscle function. And as you can see here, this is repetitive pelvic floor contraction, changes in total hemoglobin, oxygenated, deoxygenated, and cytochrome C oxidase. And using different methods that we use in sports medicine, we could look at strength, endurance, and power of pelvic floor muscles. So after that, we actually moved to a clinical trial and showed that near-infrared spectroscopy can show changes in pelvic floor muscle condition after a 6-week Kegel exercise program. As you can see here, there is obvious changes in muscle strength indicated by the amount of the amplitude of drop in total hemoglobin, also the endurance of muscle in a continuous isometric contraction of pelvic floor muscles. Again, the pattern is totally different. And the power of muscle, this is the 10 repetitive contraction, frequent contraction, and again, the pattern is different. So we think that near-infrared spectroscopy can be used as a kind of optical biofeedback system for better training of people who needs to do pelvic floor exercise. After adults, we moved to some children cases. We collaborated with Dr. Afshar at General Hospital, and first of all, we tried to see what is the normal pattern of voiding in asymptomatic children. That was pretty similar to what we observed in the adult. Again, initial rise upon permission to void, then a gradual larger increase in total hemoglobin and oxygenated hemoglobin, and then gradual decrease actually at the terminal phase or after voiding uroflow finished. That was a reproducible and consistent pattern over different cases, different children. And as you can see here, the adult normal pattern and children normal pattern are pretty similar. In our studies, we again used this compact wireless near-infrared spectroscope, and that was very easy to actually introduce this to children. There was no feeling, no sensation, no fear whatsoever, and it was very easy actually to run. It's a very quick procedure, perhaps takes 1 minute just, and was very easy to accept by children. Then we moved to some dysfunctional cases, try to see what's the difference between asymptomatic and symptomatic children. We started with some non-neurogenic dysfunction in children, and as you can see again, the pattern is different totally. The pattern is opposite. Upon permission to void, sometimes we saw this initial increase. In some cases, some severe cases, there was no initial increase. And upon the start of voiding, there was a decrease in Detrusor hemodynamics, blood flow, and oxygenation. That pattern was pretty similar in different cases, different dysfunctions. And this is another case, as you can see, upon uroflow starts, instead of increase in blood flow and oxygenation of Detrusor, there was a decrease. In fact, that was a kind of dysfunction inside the bladder muscle for getting more blood, oxygenated blood, to be able to have a good contraction. Using this device, as I mentioned, we could get another data, which is tissue saturation index or tissue oxygen saturation level. And obviously, there was a difference between asymptomatic and symptomatic patients in terms of tissue saturation, tissue oxygen saturation during voiding. As you can see, normal cases, there was a gradual increase in tissue oxygen saturation of the Detrusor, while in dysfunctional cases, there was a gradual decrease in tissue saturation. And this is a very obvious hypoxic pattern of muscle function that we saw in some severe cases of dysfunction. As you can see, upon the permission to void, as individual tried to actually contract the muscle, there was a sudden increase in deoxygenated hemoglobin and decrease in oxygenated hemoglobin. It's pretty much similar to what we see in the skeletal muscle when there is a muscle fatigue. This study done at the Department of Sports Medicine, we looked at respiratory muscle fatigue during some resistive works. And this pattern, as you can see, at SCM muscle is pretty similar to a non-functional or dysfunctional Detrusor, showing the same thing. When muscle is dysfunctional, it can't actually increase oxygenated hemoglobin during the contraction. Gut hypoxia. We think that using near-infrared spectroscopy, we can get some more data even before uroflow starts. As we know, when we use urodynamics, we start to get some data, relative data, as uroflow starts. But using the simultaneous near-infrared spectroscopy, we can get some data as we actually issue permission to void. And we are working on this part, this pre-uroflow part, to see what's the difference in terms of increase or decrease of oxygenated hemoglobin and total hemoglobin. After some non-neurogenic dysfunctional cases, we moved to neurogenic cases at ICORT with Dr. Mike Nigro. We started to look at bladder dysfunction, monitoring bladder dysfunction in people with a spinal cord injury. And the objective was to first look at the feasibility of doing NIRS for as a non-invasive method to monitoring bladder function, and look at the pattern of changes in Detrusor chromophore concentration during filling and voiding when it's possible, and try to correlate our non-invasive NIRS data to invasive urodynamic simultaneous data. We, in the first phase, we looked at 20 adult paraplegic men and women aged between 18 to 75 with neurogenic bladder dysfunction who referred to UBC Hospital or ICORT Center, Blossom Center. After urodynamics preparation and catheterization, we put our near-infrared spectroscope over the symphysis of pubis, fixed that by a surgical tape, and started to monitoring data during urodynamics, during filling and voiding when was possible. The bladder filling was at a rate of 40 millimeter per second, and data was continuously collected, urodynamics data and NIRS data. And we did the correlation analysis on those data. During the bladder filling, what was obvious was something like the asymptomatic, starting to look like the asymptomatic data, started with a gradual increase in total hemoglobin and oxygenated hemoglobin, but then decrease in both total hemoglobin and oxygenated hemoglobin. We had in 12 cases we had leakage during filling procedure, and that was very interesting. We observed, the leakage was at the mean bladder volume of 220 and the Detrusor pressure of about 63 millimeter of water. And there was a significant fall in Detrusor oxygenated hemoglobin and total hemoglobin starting some seconds before leakage happens. So that was very interesting. When I was in front of my computer, when I saw a drop starting, we could anticipate that something is happening. And some seconds later, 10 seconds later, the nurses actually report a leakage. There was a very good consistency between increase in Detrusor pressure and decrease in oxygenated hemoglobin and total hemoglobin. As I mentioned, there was a strong consistency between changes in Detrusor total hemoglobin, let's say Detrusor blood fluid and oxygenation, and changes we observed during the leakage and even during the filling part of the urodynamics. In fact, if you compare this non-invasive NIRS part with this invasive urodynamics part, You can see kind of mirror effect between these data. This data coming non-invasively from the surface of the skin. This data coming from the catheters, monitoring pressure. So it seems that based on our study so far, it seems that near-infrared spectroscopy monitoring of bladder function is feasible and can provide some new kind of physiological information related to voiding dysfunction and even filling in neurogenic bladder non-invasively. Detrusor tissue saturation was observed to fluctuate during filling and voiding. It can suggest a kind of neurovascular alteration in those cases then. That might be interesting for treatment planning and monitoring afterward. Overall conclusion, working by near-infrared spectroscopy in asymptomatic and different kinds of symptomatic dysfunctional patients, it seems that using near-infrared spectroscopy and even simultaneous to urodynamics data can provide some more insight for us to look at bladder function. That part is non-invasively, is totally non-invasive, and can actually add some information about bladder function in different kinds of dysfunction. It seems that bladder near-infrared spectroscopy monitoring might be useful screening tool, at least in high-risk patients, and bladder near-infrared spectroscopy may be useful non-invasive method for monitoring the effect of medications and treatment plans. Also, our study so far shows that ischemia perhaps impairs detrusor contraction and function. There is an association between detrusor ischemia and hypoxia and different kinds of dysfunction. In the last part, I want to just touch on base a new approach that we started to do on near-infrared spectroscopy for the first time in the literature. I'm sure everybody agrees that urodynamics is an invasive method with some inherent limitation, and perhaps finding a non-invasive method for measuring a detrusor pressure is a kind of very good thing, is a kind of desire. In NIRS study, what we actually monitor mainly in all disciplines, in all clinical near-infrared spectroscopy, we normally look at the total pattern of changes in tissue oxygenation and hemodynamics perfusion. For better study, for better look at the overall pattern, what we do, we start to filterize the very fine and even high pass movement artifacts. Near-infrared spectroscopy, in fact, is a very sensitive method. We can get heart rate pulsation or even respiration from different kinds of tissue, even the bladder. It's totally doable. But what we do normally, we use different kinds of low pass and high pass filter to filterize these fine changes in order to have a fine trend, to look at the trend of changes. This is the current practice in all clinical disciplines. By training, I'm a sports physician, so I'm pretty involved in different kinds of sports pathologies. And in one of my studies, I came across with an article proposing a new ultrasound method to look at for non-invasive diagnosis of chronic exertional compartment syndrome. The problem, chronic exertional compartment syndrome or acute compartment syndrome, is something similar to what we have in bladder. There is an abnormal increase in tissue pressure, intercompartmental pressure. So in that study, they actually introduced a new pulse phase-like loop ultrasound. This is a device that they can actually put over the skin, and they can target a fascia, and they can start monitoring the alteration of the fascia against cardiac pulsation. So as you can see here, this is a normal fascia pulsation in a low pressure compartment, and as intracompartment pressure increases, the pattern and the shape of pulsation started to change. As you can see, the complexity of pulsation actually was changed. When I actually reviewed that article, I thought that we might be able to get a similar kind of data when we look at Detrusor pressure. So I started to get back to some of our data getting from high pressure and low pressure Detrusors, and I started to unfilterize our data. I actually used the original data, and I magnified the data, and interestingly we see a very similar pattern. So as you can see here, when the pressure, Detrusor pressure is low, we can see the pulsation, very complex pulsation over the Detrusor. But as the pressure increases, this complexity and the amplitude of changes actually obviously and significantly changes. And again, as pressure actually decreases, the Detrusor pressure, the complexity and higher amplitude of changes actually returns. This is another example at a low pressure Detrusor pulsation that we can capture using near-infrared spectroscopy. Very simple, in a very simple way. And this is the same pattern in the same patient, in the same experience, when the pressure actually increases from 10 to 85. As you can see, the amplitude and the complexity of the signal is totally different, significantly different. Now we started at the Department of Urology Bladder Care Center with collaboration of Department of Electrical Engineering to look at a mathematical method to actually do a signal analysis, trying to be able to quantify the amount of Detrusor pressure based on analysis of the signal, the amplitude of changes and the complexity of changes. And this is our current work that we started at the Bladder Care Center. Thank you very much, and I'm open to any question if there is.